Good morning, everybody. Alrighty. So today we are going to finish our lecture about research methods. We don't have much more of that. And then we're going to start our lecture about assessment, diagnosis, and treatment. So I am going to go ahead and take attendance real quick, and then we'll get started in just a minute. Let me get the participants window up here. Okie dokie. So I'm gonna go ahead and get our PowerPoint set up and ready to roll. While I'm doing that, does anyone have any questions about assignments coming up, anything like that? Y'all are so quiet this morning. Alrighty. Well, I did put the review sheets for the whole semester actually up on Blackboard, so you have access to those. And it also tells you about the format for the exam. So it'll be through Blackboard. It'll be 20 multiple choice, 10 fill in the blanks, and then a short essay, really short answer, like a paragraph, and then a little bit of a longer short essay. That sounds weird, but like a couple paragraphs where you get to show your knowledge. And those will always have choices built within them. So if there's one particular theory or something like that, then you are not stuck with that. So you will be able to show me your knowledge regardless. Okie dokie, I'm gonna go ahead and screen share here. And then we'll finish, like I said, we'll finish the one PowerPoint and then we'll move on to the next one. Alrighty, and I'm gonna open the chat just in case anyone does have any questions. And just to be on the safe side, since y'all are so quiet, can someone just write in the chat and let me know you can see and hear me?
Yeah, we can see and hear you.
Awesome, thanks. Just double checking. I just heard a thing on the radio this morning that there was a professor who gave like a 2-hour lecture and he froze up in the first 8 minutes. So I don't want to be that person. Okay, so we had just finished talking about, in general, about the experimental method. But it's also important to talk about, just like we talked about for the correlation method. Oh, real quick before I get on, Anaya had a question about where I put these lectures. So let me show you that real quick, because I'm sure other people might be curious. So I'm going to screen share my browser. You're going to see my email for a sec. Don't judge how many unanswered ones I have. So if you go to Blackboard, and you go into our course, this is probably the easiest way to find it. Oh, good morning, Simba. You will see one that says video recordings of class lectures. And so whenever class finishes, I upload it to YouTube. And then as soon as the YouTube is done, I put it here. If for some reason you can't get on Blackboard, if you just go to YouTube, oh, hi. And you search Taryn Myers, I should come up. I do have a channel for all these videos. There I am. Ooh, my 22 subscribers now. How exciting. And there's a whole playlist for just abnormal stuff. So, and if you ever had any desire to watch any of my other stuff, it's up there. But probably going through Blackboard will be easiest. Like I said, I try to do it usually, so I teach again at 1, and usually I try to post it before 1 so that it's there. Like another question in the chat. Oh, perfect. Yay. Glad that that was helpful. And I'm sure helpful for other people too. So if you, miss a lecture, or if you, just want to review, because I do talk quickly, then you certainly can do it that way. Yes, I know. I have to teach now, okay? You can chill there though. Okay. All right, so extensions of the experimental method. So there are what are called quasi-experiments. So at times we're going to have a type of group we want to look at differences in, but that we can't randomly assign. So for example, something like gender, race, something like, being abused as a child, right? We would never want to like randomly assign someone to be abused. But what we can do is use those groups as they exist in nature, and then use those to actually put these things forward and study them. So you would take people who have been abused, who are willing to talk about it. Obviously, you never force anybody into this. And then you would take people who have not been abused and you try to match them on age, demographics, things along those lines. And then you compare those groups. And so they're called a quasi-experiment because you can't actually randomly control, but they are actually, still experimental in that you can still look at the effects of those things having happened. And you might even do something where you bring people into the lab and have them do tasks, and just, the one variable you can't randomly assign is this, but maybe you randomly assign them to do the A version or the B version of a task. Natural experiments occur when nature itself or some sort of larger human-made phenomenon manipulates the independent variable. So natural disasters are a big part of this. Another example is September 11th. So, I was in college when September 11th happened. The feelings around it, and I didn't even know anyone connected to it, right? But the feelings around it were really similar, I think, to what some people experienced on January 6th of this year in terms of not knowing what's happening. If you had, friends, family that worked in those areas, being concerned about them the whole time. And obviously we'd never want to cause any kind of terrorist attack. But, we can use research about these types of things to try to help people when the next disaster hits. So for example, after September 11th, people did research on a whole host of topics, like, who had PTSD. When we talk about the PTSD chapter, we'll talk about some of that research that they did, just predictors of who would develop it. Things like how much therapy helped, and even things like higher incidence of alcoholism among the Red Cross workers who helped after the attacks. So all of those things obviously can be really helpful. And in fact, a lot of what we learned from September 11th was applied when, say, the tsunami hit and there was the nuclear reactor meltdown at Fukushima. Actually, I have a friend who now actually works in Asia, but that was sort of his first foray over there. He actually went over as a therapist immediately after that happened to try to help people process things. And a lot of the work he was doing was informed by what we learned from September 11th. So again, we never want to take advantage of those people. We always want to make sure there's informed consent. But we also want to recognize that there is knowledge to be learned that can hopefully help others in the future. All right, and then analog experiments are using animals in the lab to examine abnormal behavior. So I was looking up something related to this recently, and they breed all kinds of strands of mice now that can process things in different ways or kind of look like they have depression. And we could certainly debate the ethics of this and You know, to be perfectly honest, I don't even know where I land on this anymore. Certainly our neighbors at PETA right over there in Norfolk. I don't know if you all realize that, but that's PETA's national headquarters that we have over there in Norfolk. They would obviously be very against it, but there are some things that we've learned through mice we couldn't learn from humans, or that allow us to lead up to humans. So as my ethics professor in grad school used to say, it's a sticky widget, right? It is something that there's not one good, clear answer to for a lot of people. There are going to be people who there is one way or the other, right? And sometimes these studies can be done with minimal harm to the animals, right? So if we think about something like the famous ape Coco, who they taught sign language to, right? You know, they weren't doing anything to abuse her. They were rewarding her. And in fact, it probably improved her quality of life as a captive ape to be able to communicate with her keepers, right? Does that mean I am in total agreement with keeping wild animals in captivity? Not necessarily, right? But you can kind of see some of the positives that might come out of it. All right, and then there are what are called single case experiments or single subject designs. And these are doing a case study, but in an experimental framework, essentially. So it's doing an experiment with a subject, sample size of one person. So the same individual studied over a period of time, and their behavior at one point in time is compared to subsequent time points. And it usually then what you're doing if we're studying abnormality is introducing some sort of treatment or intervention. So the most common case, single case experiment design is what's on here, the ABAB design. All right, so the first A, those letters just mean the different phases of the study. They don't actually mean you're doing something related to the letter A or related to the letter B. So the first A is your baseline. You're just going to measure how that person's doing before you do anything. The first B is where you introduce your independent variable. And again, in this sort of abnormality situation, this would be some sort of treatment. Maybe a single technique, maybe a type of therapy, things along those lines. And then what we want to do is see, is there a change from baseline? If there is, that's great. But because we only have one person, we don't know if what we did actually caused that, right? So like, let's say we're trying to treat someone for depression and we start applying a therapy, but at the same time, they like get a new job, right? So we don't know if it's because we applied the new therapy or because they now are going to have a livelihood, right? So then what we do instead is we will actually take that treatment away for a short period of time, especially if it's helpful, right? We don't want to deprive them of it too long, but maybe a couple weeks or, you know, depending, a couple days, a couple hours, right? And so we're sort of back to baseline and we say, what's happening now? What's happening now that we took that away? And then if, you know, things revert, or even if they don't, we might reapply B and see if it makes a difference. And I think this is most easily understood if we look at an example. So this is the case of Chris, and this is not a client I've seen. This is just a case study that's used pretty frequently for examples of single case design. So Chris was a 19-year-old female who had developmental delays. So she probably processed things more like an 8 or a 10-year-old. Since the age of 3, she had pulled her hair out of her scalp. This is an impulse control disorder called trichotillomania. We don't talk about this in class other than right now. So if this ends up interesting you, sorry, I'm typing it in the chat here, it certainly would be a good group topic. All right, so with trichotillomania, you pull your hair out, sometimes related to anxiety, sometimes related to stress, sometimes you're just sort of doing it because you're used to doing it. I've known one person, she was actually a student, who developed trichotillomania. And I could tell how stressed she was by how much of her eyebrows were there. She actually pulled out her eyebrows. It doesn't have to be the hair on your head. It can be on your arm, on your legs, in your pubic region. And so like when she came in one day with like half her eyebrow gone, I knew like, okay, we need to see what's going on with you. And it was like, she was having like a life crisis. And I talked her through it and she got into grad school and now she has her own private practice. So, you know, it worked out. So Chris had this, but the problem with trying to treat someone with developmental delay is that all the therapies designed for trichotillomania require a fairly decent level of intellect or cognitive ability. So they're asking you to like think about what you're thinking in that moment. They're asking you to write things and process things and be aware of things. And that just wasn't going to work for Chris and where she was developmentally. And her trichotillomania was so severe that she actually would end up with bald patches on her head because she did pull it out of her head. And so clearly they didn't want to just like let this go. And so they ended up using an AB experimental design to see if a simple behavioral treatment was actually helpful in reducing her hair pulling. And a video camera was used to monitor her behavior while watching TV because that was the most common time she did it. So as you can see, the baseline's pretty long here. You know, I don't have the full information about this case, but my guess is they were trying a whole bunch of other things, right, in the meantime. And it looked like sometimes they work temporarily, but then not really, right? And so this is like the percentage of time while she's watching TV that she's manipulating her hair. So like 80% of the time, she's sitting there pulling her hair out. That's not great, right? It's not great for her scalp. That's not great for her hair. It's just not great as an untreated behavior, right? So what they decided to do after trying all these other things is they got wrist weights, little 2.5-pound wrist weights. And they would put them on Chris's wrists and then observe her while she watched TV. And the idea was that because it was a little heavier than usual, Chris would notice when her hand went up and she started to pull. Because what happens a lot with trichotillomania is it just becomes such an ingrained behavior that you don't even notice you're doing it. This is similar to people who like tap their fingers, right? Or like chew on a pencil. Most of the time they don't even realize they're doing it, right? So they put this weight around her wrists while watching TV. And when she had the wrist weight, her hair manipulation went down to 0% of the time. That is fantastic. But as we can see, if we look back at this long baseline, there were a couple other times where it went down to 0, right? So they didn't want to be like, hooray, we found the solution. So they did the second A. They took away the weight to see what would happen. And what you see is it went back to sort of her average amount of hair manipulation, somewhere around 60% of the time. So then they put the weights back on and it stopped. And now, would this be a permanent solution? Probably not. But the hope with behavioral things is that by doing it for a period of time, it sort of essentially unconditions that behavior, untrains that behavior, and then you don't have to do it anymore. So again, sometimes you have to get really creative if your client just can't interface with the type of therapy that's out there. And this is a really nice example of that. Alrighty, and this is just sort of a, a funny little cartoon about some of these concepts we've been talking about. And it also kind of reflects on concepts that we'll talk about starting in our next lecture. Now, one thing I don't know why I've never put in my slides, because I have it in my notes and I talk about it every time, but that I've never put in my slides is to talk about the differences in significance, right? So we talked about statistical significance. And typically when we talk about statistical significance, you'll see something like this. P is less than 0.05. And what that means is according to probability, there is less than a 5% chance that this happened just because. There's a 95% chance that this happened because a real relationship exists between these variables. That, however, is just called statistical significance. Okay, and that means When we run a statistical formula, essentially, or a program does it for it, then it tells us, yes, there is a difference or there's a relationship. And it's essentially, did it occur because of treatment? Now, you can have statistical significance, especially if you have large sample sizes, and have the difference actually be very small. So for example, if you have a very large sample size, you could have, let's say we're studying control group versus experimental group, and our experimental group is our treatment, right? You could have different reductions in depression, but maybe for your control group, you had 2.5 points on the scale of 10 go down. And maybe for your experimental group, you had 3 points go down on a scale of 10. That's great, it's different, but does that actually make a difference in the client's life, right? Is it worth the effort for that small amount of difference? Because sometimes, again, if you have really large sample sizes, it might be like 0.5, or that was point, like 0.05 difference. So what we really want to think about is what's called clinical significance. And I'm putting these in the chat if y'all aren't seeing that. And clinical significance is, does it actually improve their quality of life? So does that small difference in depression actually make a difference to how the client is functioning? Or, you know, if we're looking at a correlation, does a very small correlation actually make a difference in the grand scheme of things? And I think that's really important to think about in something like abnormal psychology, clinical psychology, because we get really excited and really sort of wrapped up in the stats of things sometimes, I think. But we need to step back and really think about the implications. Like, does this actually matter for people's lives, right? We know that these are people that we're actually working with. They're not numbers on a page or in a spreadsheet. So that's really important. And a lot of journals that I publish in now are actually asking people who write these things to include a whole section in their discussion section talking about the clinical implications and how these things actually apply. So that's very important, I think. All right, I am going to click us out of this PowerPoint. I'm just going to double check on our attendance, just because I know at least one person has come in here. All right, I want to give everybody credit. Make sure I'm not bugging anybody who was actually here. Alrighty, and so now what we're going to do is we're going to start the next lecture, which is about assessment, diagnosis, and treatment. This is really a lot to jam into one chapter. So for those of you who might be interested, who are sophomores or juniors, next spring, I will teach a class, I teach it every other spring, on clinical psychology. And so if this lecture really gets your attention, my lecture on clinical my class on clinical psychology essentially focuses on this next lecture for an entire semester, right? So I think that that's really important to note, is that a lot of what we look at in classes like abnormal psychology is really condensed and compressed, because, oh good, Allie loved it, yay! Even though we had weirdness and we ended up being remote half the semester. But yeah, it's important to kind of know that this is a survey course. This is why this is one of our 200 level courses, because it sets the foundation to get into the stuff in more detail. And then honestly, if you're interested in assessment in particular, in fall, I'll be teaching a whole class about assessment. So that's another option as well. And if you're thinking at all that you want a sort of clinical career in psychology, social worker, counselor, what have you, I highly recommend both assessment and clinical psychology. People sort of poo-poo assessment, I think, but that is a lot of what you do as a clinician. You're going to do an intake on any person who comes to see you. You might do assessments for various conditions, various neurological conditions, things along those lines. So if that's sort of the route you're thinking of going, highly recommend assessment in the fall, clinical in the spring. All right, now that I put my plug in, we can go back to actually looking at this lecture. So these are really more, so most of what we'll talk about this semester is like the what of what the client comes in with. This chapter is more about the what of what the clinician does, if that makes sense. So we're gonna start by talking about, first I have my abbreviations. So again, I talk quickly. These are abbreviations I've learned over the years that may be helpful to you if you are a hand note taker. So you can use BX to mean behavior. You can use DX for diagnosis. Sorry. Believe it or not, that's better than yesterday. D/O is often used to refer to disorder. HX can mean history. If you use the psi symbol, the Greek symbol for the letter psi, we can use that to mean psychology. SX means symptom. One thing, heads up, if you do end up going into more of a medical psychology type field, or those of you who are rec therapy majors and might be interacting more in medical settings, this can also mean surgery when you're working with MDs. So just sort of heads up with that. And then TX is treatment. And that could be therapy or medication. So again, you don't have to use these. I just include these because they're things that I developed over the years, and I still use these when I take notes at conferences now. So, all right, so we're going to talk about assessment. So it's basically sort of like, how is your brain doing? How is your mind doing? How are you? But in a lot more technical terms. So assessment is the collection of relevant information in an effort to reach a conclusion. And remember, as I mentioned last lecture, now that we're in this section, we're talking about assessment, we're looking at idiographic information. So we want to look at that individual in front of us who we are assessing, what's going on with them. And remember, in research, what we're looking at is the nomothetic information. We're looking at more general information, that name level for the disorder. And its nature, its causes, its treatments. When we're doing assessment, we're looking at that person on the chair opposite us, across the table from us, and we're saying, what's going on with you and how can I help you, essentially. So clinical assessment is largely what we'll talk about, obviously, and it's collecting information to determine how and why a person is behaving abnormally. So I'll say that again. So collecting information to determine how and why a person is behaving abnormally, and then as a result of that, how that person can be helped. So just give you a quick example of that. So our training clinic, we saw a whole range of disorders, but there were certain things we just weren't equipped to treat. So if anyone came in and their primary concern was substance abuse or dependence, we actually would refer them to a residential treatment center in town because they had the medical supervision for when a person was detoxing, right? Like we didn't have that in our training clinic. So it would have been potentially medically dangerous because a lot of scary things can happen when a person is withdrawing from drugs medically. Similarly, we weren't equipped to treat people with active psychosis. So we had other referral information for those folks. But if someone came in and, they had depression, anxiety, things along those lines, they could be referred to pretty much anyone. And our first year of doing things, we used to saw sort of a potpourri of clients. And then if they came in with something more specialized, like an eating disorder, they'd be referred to people who were in the eating disorder practicum. If they came in, wanting to be assessed for ADHD, we had a neuropsychological assessment practicum, things along those lines. So that's clinical assessment. You're trying to figure out what's going on with this person and how can I help them? Is it me? Can I help them? Or do I need to refer them to someone else to help them? And what services do I need to give them? right? So if someone came to you for an ADHD test and you started doing treatment for, you know, schizophrenia, right? That would be unethical and problematic, right? If that person didn't have that disorder. So assessment gives us a lot of good information. It can also help to monitor progress throughout therapy. So a lot of the modern evidence-based therapies will actually include assessment every week. So the client comes in before they go in with their therapist, they fill out a quick questionnaire. We use that to monitor their symptoms and see what's happening. And, you know, obviously we want to see a general downward trend. If there's an uptick, we want to know what's happening. Is it that, you know, we as therapists are doing something wrong, or is it something changed outside of therapy? And we need to address that this week. A really key part of clinical assessment is standardization. This means setting up common steps to be followed whenever you do that particular assessment. So down here in the corner, there's actually a picture of individuals doing what's called the WAIS, the Wechsler Adult Intelligence Scale. I have that in later slides, so you don't need to worry about scribbling that down now. But it is probably the most standardized test we give. So there are, you can kind of see it down here. So she's got this book propped up. That is the manual, and it gives you exact instructions to read out loud. And it also gives you things like when she set this up, she actually had to put this book a certain place on the table. She had to put these blocks down in a very specific way, a certain amount away from the client. So the idea is if I gave it, if someone gave it in Missouri, if someone gave it in California, we should get the same or at least very similar results. So the idea is that we want them to have the same experience or opportunity if it's administered in the correct way. There are some caveats to that we'll talk about at the end of this lecture that I think are really important. So we'll probably get to those on Tuesday. Alrighty, so reliability is very important. And in fact, we're going to talk, these next two slides, we talk about reliability and validity. I basically, my first semester of grad school, took an assessment course and it only focused on reliability and validity for an entire semester. So again, I'm doing two slides, but clearly these are really important constructs in assessment. So reliability refers to consistency of measurement. So is this actually measuring the same thing every time we do it? And there are different types of reliability. So one is Interrater reliability, and this refers to the degree of agreement between two observers. And this is like if two people watch the same thing, do they get the same score? Do they agree? And this could be watching someone behind a one-way mirror, watching a video, watching them live. It could be just reading something that they wrote and using a coding sheet. Are two people rating it the same way? And I have down here, it's so ancient now, but a picture of the original American Idol judges to give an example of poor Interrater reliability, right? Because I don't know if you all remember when these three were judges, you might have been young. You know, Randy would always say something like, "Yo, dog, I liked it, dog. It was a little pitchy, though," like almost every time. Simon Cowell is just Simon Cowell and just be like, "That was horrible. There was nothing good about it." You know, this gesture a lot. And then Paula Abdul, sweet Paula Abdul, I grew up listening to her music, would say something like, "That was wonderful, and you just look so pretty." Okay, so clearly really poor Interrater reliability, not something that's great. We obviously want much more agreement than that, but obviously that makes for better television than if they all said the same thing. Test-retest reliability refers to the extent to which scores are similar for a person if they're taking the same test twice. So let's say I give it to you now and I give it to you in 2 weeks. Do you score similarly? And now there are tests we want to be really reliable in this way. Intelligence tests, things about personality traits are supposed to be stable over time. But there are other things that we hope don't have great test-retest reliability if we're doing treatment, right? So if I have been doing full treatment 20 sessions with someone for depression, and they're testing the same on depression as when they first came in, right? That means I'm not doing a very good job. So we want to see that change over time in some cases. And then internal consistency is honestly the type that we talk the most about in research when we're talking about reliability, because these things can all be applied to clinical research as well. Are the items on an assessment all measuring the same thing? Are they related? Right, so the silly example I always give for this is, let's say, I think of depression again is just the easiest example because everyone can kind of resonate with it a little bit, right? So let's say you have a questionnaire about depression and it's like, I'm feeling down, I'm eating too much, I'm sleeping too much, I like ice cream, I can't have trouble concentrating, right? That I like ice cream item is weird because, you know, that like intelligence isn't really going to relate to depression and would probably throw off your internal consistency. Now, validity is the accuracy of a test results. Is it actually measuring what it says it's measuring? So imagine this, you could have a really reliable test that's just not measuring what you think it is. So let's say you developed a test for depression, you called it a depression inventory, and it was all questions about ice cream. I like vanilla, I like chocolate, I like to eat ice cream with friends, right? You might have great reliability, but the validity is going to be lacking because it's not actually measuring depression, but you're calling it that, right? So this is another really important element of assessment, particularly clinical assessment, where you're going to be making decisions about that person's life, right, and how you're going to help them based on your assessments. So is it measuring what it's supposed to be measuring? Is it fulfilling its intended purpose? Types of validity, face validity is, does it look like what it's supposed to be measuring? And again, sometimes you want this and sometimes you don't. So something like a measure of depression that does ask things like, I've been feeling down, that has face validity and that's fine. That might be what we want. There are other types of assessment that are not going to have this, and that's also okay. So for example, for years and years and years, the starting item on the MMPI, the Minnesota Multiphasic Personality Inventory, was, I enjoy reading mechanics magazines. Okay, and it's so random, but just the way the MMPI was created, that was just part of a larger system, right? So someone who started taking this would be like, what the heck are they asking me about, right? And that's okay too. Predictive validity is, can it predict what will happen in the future? So this is really important clinically because there's a bunch of things we might want to predict in the future. If our client is suicidal, we want to predict that they will be able to see us next week because they'll still be around, right? If we're doing therapy with them, we want to be able to predict that that therapy will actually work. Then there's concurrent validity, and that means that if I'm measuring using two measures, let's say, again, of depression at the same time, that they're going to agree. They're going to essentially correlate really highly. It's going to show that they are in agreement. And so a lot of times, let's say we're developing a new measure of depression, we might give it to people who we know are diagnosed with depression, and do they score differently than people who are not? Or how do scores on this new questionnaire about depression relate to a clinical interview, which is often the gold standard in diagnosing someone? So that's concurrent. At the same time, predictive is, can what I measure now predict what will happen in the future? Content validity is that, is essentially, is the measure adequately getting at everything that's part of what you're trying to study? So if I created a depression questionnaire and I only asked things like, I've been having trouble sleeping, I've been having trouble eating, I've been jittery, right? Those are all symptoms of depression, but they're also symptoms of anxiety. They can also be symptoms of physiological problems, right? So that's not actually going to be a depression measure with good content validity. It's not getting at the full spectrum of what depression is. And then construct validity essentially is sort of like an overarching term for predictive, concurrent, and content. And it's essentially whether a measure of a construct is supported by the existing measures of that construct. Does it relate to those? So again, if it's a new measure of depression, does it correlate with existing measures of depression in some meaningful way? Also sort of inherent in this is it adding anything, right? Like, are we really going to push for a new measure of depression that doesn't add anything when we've got really good existing ones? All right, so we're going to start talking about that gold standard, about that clinical interview. And as I mentioned at the top of this lecture, this is important. No matter what level clinician you would end up being, you know, again, social worker, counselor, or clinical psychologist at the master's level, PhD, or PsyD psychologist. Honestly, even if you were an MD psychiatrist, the very first thing you're going to do when a client comes to see you is some sort of intake interview. So you're doing assessment with every client who comes in the door. And so what you're going to do is collect details about the person's life and their circumstances. And this is, you know, sort of the psychological version of what happens when you go to a new physician, right? They have you fill out information about your medical history. This is going to get at your overall psychosocial history. And there are a couple different types of clinical interviews here. So one is the unstructured interview, and I would say this is the most commonly used one. This is, you're just asking them open-ended questions and saying things like, tell me about what brought you here today. Tell me about your previous psychiatric or medical history. What's it like for you in your home right now? What sort of support systems do you have? Okay, so this is really, really important because this lets you get to know that person. And why it's called unstructured is it's not scripted. I mean, a lot of times therapists will develop their own sort of set of questions they typically ask, but you can deviate from them without, you know, like messing up a standardized test. So, you know, if they say, oh, well, I, you know, have really been struggling with anxiety, you don't have to just be like, check a box about anxiety and move on. You can actually sort of say, okay, well, tell me more about that. What sort of anxiety? What situations are you anxious in? That type of thing, to get more of a full picture. And you can also skip questions that you would typically ask if you immediately know they don't apply, right? So that becomes important as well. Typically, when you do these in the real world setting, you get about an hour, maybe 45 minutes. And that's all you get to know the person. And if you're in a managed care system, something where there's some sort of insurance, you know, again, be it, you know, through the VA, be it through a private insurer, Medicare, Medicaid, what have you, at the end of that hour, you've got to have a diagnosis for the person. That is a challenge. So when I was in my training clinic, we were given as much time as we needed to assess the person and come up with a diagnosis. So I might have a 3-hour intake interview. But once you're out in the real world, it's very, very different. So you have to get pretty good at doing this and executing it in an accurate and efficient manner. And it's a way of gathering a lot of information from clients. And another thing is you also observe them. So you're looking for nonverbal indicators of what might be bothering them. So if they, you know, come late to your appointment, if they Show up looking like they haven't showered in a week, right? Those tell you things like there might be some confusion. They might be having problems with basic hygiene because they're so depressed. If they avoid specific types of questions, that can be almost as informative as if they answer them, to be honest. So if every time you bring up something related to drinking, say, they just sort of change the subject, right? You sort of want to file that away as I want to probe this more later because clearly something's going on substance related. I do not envy clinicians who are having to do this all virtual now. There are some great HIPAA compliant, safe platforms you can do, but it's not the same as being in the room with the person, right? You can't see everything they're doing. So if like their leg is jittering while they're talking, you're not gonna be able to see that. I've shared this in my other classes. I don't know if I've shared with y'all yet, but I experienced postpartum depression and postpartum anxiety after I had my child 2.5 years ago. And so I'm like stepping down my therapy with my therapist. We only see each other once a month now. But obviously for the past year or so, it's been on a platform like Zoom. It's a different platform that's encrypted and whatnot. And my therapist has shared with me, she's like, this is really hard. I can't always tell, you know, the detail of facial expressions. It's not like being in the room with you. So she checks in with me a lot more about how I'm doing. And again, I can't imagine like having to meet someone for the first time over Zoom and assess them and then treat them. I would just feel like I'm just missing so much information, right? So that is the unstructured interview. And again, every clinician who sees a client should be doing some version of this the first thing that they do. The second type of clinical interview is the structured interview. And here the therapist asks the client about their symptoms they're experiencing, and the format of the questions is highly standardized, just like the instructions for the WACE, for example, that we just talked about. And the person's answers in the questions are scored according to usually the criteria for a disorder. So I have the example of the SCID-4 on here because that's someone I was trained with. Obviously now we're on the DSM-5 and we're gonna get to the DSM later in this lecture. So the one that they would use now would be the SCID-5. But back in my day, before 2013, we used the SCID-4 because that's what it was. I just feel so old sometimes when I say stuff like that. So the SCID is an example of a structured interview that's supposed to get at essentially all of the common diagnoses in the DSM, that basically all the common diagnoses that clinicians see. Now, it doesn't drill down into super specifics for things like psychosis. There are other interviews for that. And then there are other interviews that are just more detailed. So for example, when I was at the VA, we learned to give the CAPS, which is the Clinician Assessment of PTSD Symptoms. And that one is much more specific than the SCID PTSD section because it is written specifically for that disorder. But this is an example of a question I had memorized because this is the first question you asked on the SCID to everyone you gave it to in the past 2 months. Have you been feeling depressed or down most of the day, nearly every day? I didn't even need to read it. I still got it up there. So, you know, and then based off of how they respond, there are probes that are written into the script of like, how long have you been feeling that way? And then you go through the rest of the symptoms. The structured interviews also have sort of like step out, stop outs. Like if they say no to this and no to the next question, then you skip the rest of the depression questions because they're not going to meet criteria for depression. So these can be really helpful. However, it is rare to give these in a like private practice setting. We typically see these in settings that have more flexible times. So things like the VA, we did give the CAPS because you're less restricted in the time you can spend with people there. And in our training clinic, because students weren't paying, again, we could take as much time as we wanted. Every single client actually got the skid. And that was for research purposes, but it was also for our purposes, training us as clinicians to learn to recognize these symptoms. So it got to the point that when I was on my residency, and again, I didn't have time to give a full skid, I had learned to do like a mini version of the skid, essentially, in the time frame that was allotted. Alrighty. So another thing that you would do in a clinical interview is called a mental status exam. So a mental status exam is a set of questions and observations that systematically evaluate awareness, orientation, and orientation is like essentially, do you know? And we look for orientation to person, time, place, and situation. So person, who are you? Time, what day is it? Place, where are we right now? Situation, why are we here? So things like, what is today's date? What city and state are we in? What building are we in? What floor are we on? Now, really interestingly, most of the time we don't do a formal mental status exam, but we're still doing one based on observations. Did the client find your office and show up relatively on time? They're oriented to, what building are we in? What floor, right? Again, things like, does the client look fairly put together, like they've showered, right? And you adjust the standard based on who you're seeing, right? So if I was seeing someone who was working in a corporate setting, I would have a different standard for that, knowing they were like ready for work or coming back from work, than if I was seeing a college student, right? If a college student showed up in my office in, sweats and a hoodie, I wouldn't blink twice. If someone told me they just came from a Wall Street job in sweats and a hoodie, I would be concerned, right? So that's a big piece of this. So again, a lot of times you're just doing this informally, using your clinical judgment. If that person is having a hard time finding your office, et cetera, or their presenting complaint is something to do with memory, attention, things along those lines, then you would do a formal mental status exam. And those exist, and they are also standardized. So there's like the 3MS or the MMSE, and these are just different versions of mental status exams that you can give people. And then those allow you to figure out what else you need to do assessment-wise to help that person. Other things we look at are attention span, memory, judgment, thought content. So do they kind of seem to be with us in the world? Just their mood. And as I mentioned already, their appearance. And appearance is not only how they're dressed, it's, how they act. So someone who's depressed, and I'm not always good at doing this since I'm a peppy person, but they're going to probably speak like this in a monotone, and it'll seem like it's hard for them to get their words out, right? Whereas someone who's really anxious might kind of speak like this and like have some pauses where they have to like think of the right thing to say, right? So just their communication style can tell you a lot about how they're feeling sometimes as well. Now, in terms of limitations for interviews in general, they may lack validity or accuracy depending on what you're asking, right? You might be missing out on getting at the full picture of what's going on if you're not asking questions about it, right? And so that can really have a negative impact. They can also lack validity because people can't always report accurately. Right? I can ask someone something, but if they don't yet realize it themselves, they might not be able to answer it. And again, I'll use myself as an example just so I don't have to use a client, but I remember when my daughter was about 5 weeks old, my folks came to visit for the first time to meet her, And I was like sitting on the couch crying, telling them, I have to watch myself for signs of postpartum depression. That's such a clinician thing to do. And like clearly I was already experiencing it, but like I wasn't recognizing that yet, right? And that can happen with a whole host of different disorders that people are experiencing, where it's like they know something's wrong, but they can't name it yet. You also have the potential for interviewer bias. That can unfairly influence how a clinician interprets results. So I told you all on Tuesday about the psychiatrist I knew who didn't believe that depression by itself was a thing, right? So he would never diagnose someone with just depression because he always thought they just had bipolar disorder. This is not accurate. It was his own thing, right? But clearly there's an example of bias, right? I was always looking for eating related things. And sometimes that might be a bias. I might focus too much on it, but it also meant I could miss some stuff. So I remember I was doing a comprehensive neuropsychological assessment on a client who was being seen for therapy already by one of my fellow students in the training clinic. And when I did one of the tests we're going to talk about here in a few minutes, the incomplete sentences, she was writing a lot of stuff about food and eating. And so I brought it up to her therapist and said, is this something you all have ever talked about? And she said, no. And she later told me like that was a new direction they went in because I picked up on that. Now, would she have suffered had I not? Probably not. She was still going to get help from my friend. But it, you know, sometimes that different perspective can be helpful. Interviews may also lack reliability because people respond differently to different interviewers. So you might respond differently to someone who is of a different sex than you or race than you, right? You might respond differently if you're not comfortable with that person. Another example I can give here, again, being pretty vague to keep up confidentiality, there was a male client who came into the training clinic. And again, I think I've mentioned before, we were all within the same web of confidentiality. So we were allowed to talk to each other about our cases in general terms, you know, just so we could learn from each other and offer each other support. And so after his male therapist did his intake with him, he came in and talked to those of us who were in the clinic about it. And we were like, you know, why did he want a male therapist? Was he just more comfortable with you? And he said, no, his problem is an impulse control problem where he's masturbating for 6 hours a day. Which, like, that sounds like that could cause physical problems, right? But clearly that guy was going to feel more comfortable talking to another guy about it. And that might not always be the case. Some guys might feel more comfortable not talking to another guy about that, right? But sometimes that therapist match can be really important to get that information out of people. And also the situation, right? So for example, when I was on my placement year working at a hospital setting while I was in grad school, I did pre-surgical interviews for people who wanted to undergo bariatric surgeries. So what they used to call stomach stapling, but is now gastric bypass, gastric banding. And at that time, they were just starting to do gastric sleeve. And people were often very defensive in those interviews because they thought of me as standing between them and their surgery. I didn't see it that way. I essentially saw myself as a way to help them succeed on their surgery. If they did have a disorder that wasn't treated, that was going to get in their way, but they didn't always see that. So they could be quite defensive, I think, in a way that would be very different than if they came to me just as a therapy client. Alrighty, so there are a whole host of clinical tests, and we will continue talking about them on Tuesday, but I do want to get through the projectives today. So the projective tests are what we typically think of, I think, when we think of clinical assessment, because they're the ones that are fun to put in the movies. And one thing I'll just say here real quick is the meaning of a test in psychology. So a test is a device for gathering information. A test is a device for gathering information. Again, we don't have those UPC scanners, so I can't just bleep and know what's going on with you. So I've got to have some way to get at that information, and that's what these tests are. And in particular, obviously in clinical settings, we're looking at their psychological functioning, from which we can infer broader information about the person, is the idea. But the biggest thing is know that it is a device for gathering information. So in projective tests, we are giving them vague stimuli or open-ended directions. And the idea is that because they're so vague, they are going to project their personality or their abnormality onto their responses or into their responses. And this is used primarily by psychodynamic clinicians to try to assess unconscious drives and conflicts. But certainly, and maybe strangely, a lot of clinical places, particularly in the Northeast, use these in hospital settings. So when we were in grad school, we actually specifically asked for a training about the Rorschach, which is the most famous projective. We'll talk about that one on the next slide, simply because we knew that these residency sites required it at some point. So I've given 2 whole Rorschachs in my whole life. They gave me some interesting information, but I don't know if the time invested was worth it. And I'll get into that more on the next slide for y'all. One thing that's really important to note about these projective tests in general is that the validity of them has been called into question repeatedly because they are so subjective and can be rated in some ways however the interviewer chooses. Now, to combat that, several projectives have actually been developed with standardized scoring systems, or standardized scoring systems have been developed for existing projective tests. So the Rorschach is one of those. And I was actually trained in one of their, probably the most commonly used standardized technique, and it's called the Exner system. I'm throwing that in to the chat, and that's just because the guy who came up with it, his name was Exner. So the Rorschach is a series of ink blots, and individuals are asked, what might this be if you're using the Exner system? Or you might see, tell me what you see, things along those lines. But I learned, what might this be? And then they give you responses, and you get to go through with the Exner system and like query them about it. So like, why does it look that way? Which part of the blot are you using? And things like content, color, texture, all of those things come into play as to how you score it. The Rorschach was originally developed from a parlor game where people would describe ink blots they made by dripping ink on a piece of paper and folding it in half. So that's why all the ink blots are symmetrical. So this parlor game was called Mulatto, and this is where this came out of. Let's see. The one thing I will say, so this is actually right here, blot number 1 on the Rorschach. Technically, I'm not supposed to show you that because it is actually copyrighted material. When I got to Wesleyan, they bought me a set of blots, and I believe it was about $75. So if you take assessment, you get to see the actual blots. And this is my old cat, Finley. She actually passed while I was pregnant. And I had picked these up from our training clinic to take to the hospital to give to somebody. And I put it out just to see what she'd do. And she stared at it for a while. I wish I could like speak cat and see what she saw. But I will show you real quick. Let me find the page, and then I'll show you why I don't care about showing you that. So this is the Wikipedia page for the Rorschach. And if you scroll down, it has all 10 blots, including popular responses for each blot. This is essentially a cheat sheet for the Rorschach, and it's really problematic. When it first was posted on Wikipedia, they tried to get it pulled and they couldn't. So if you ever want to see all 10 blots from the Rorschach, they are in fact here. And so you'll see that some are just all black and white. Some do have some red in them, and some are more colorful. And if you're a clinician and you've stared at this stuff enough, you develop a favorite blot. This is my favorite blot. I just really like the colors. One thing that I will point out that if you're looking at these, you might already be kind of guessing is that, yes, because they're from the psychodynamic perspective, some of these things are supposed to look very Freudian. Like, this is a phallus. That's on purpose, right? This kind of looks like a vulva. That's on purpose because they want to see if you will say stuff like that. So again, that's why I don't mind showing you block 1 because they exist on this other platform. And I should have worn it today, but I actually just recently purchased a dress that has some of the blots on it, which I love. So I'll probably wear it when I talk about assessment in one of my other classes this semester. And I will make sure I show you all. So again, this is something that it takes about a half hour to give. But then at least because I was new to it, the 2 that I took me about 6 hours each to score. Whereas some of these other ones we're going to talk about this today and really into next week take more like 45 minutes or 5 minutes to score. So for me, even though I got some interesting information about the client out of it, particularly about effort and things along those lines, I don't know that it was worth it over and above what I got from the other stuff. The thematic apperception test, or TAT, is a series of black and white cards which show ambiguous situations. So subjects are asked to make up a story about what's going on in the picture, and then who they identify with, the emotions they express, and recurrent themes are all used in interpretation. So fun thing I often do here, and I'll sit to do this, is ask you all to interpret this one. So basically they just ask people to come up with a story about this one. So you can either unmute or put it in the chat. If you were asked to look at this picture and tell a story, what do you think is going on?
It looks like maybe the husband just died and she's crying because he just died.
Yep, that's a common one that I hear. Yeah, the husband passed. I've heard people also say, you know, maybe the wife is ill and the husband and is finds him drunk and he hit her. Yeah. Grim Reaper. Oh, I like that one. Some people have said it looks like one of them cheated on the other. I've heard both that the husband cheated on the wife and the wife cheated on the husband. They had an argument. Yeah. And so, but the TAT, it's really interesting because the TAT is not standardized at all. But the TAT, there are 30 of these cards, and you rarely give all 30. So you would sort of pull a set, and there are recommended sets you can give and show them and see how they respond, and you look for patterns over the lot of cards that you give them. Let's say you give them 10. So if like everyone they do has to do with death, right? If they also look at this one of the 2 women and say, oh, she's also the Grim Reaper, right? Then it doesn't mean that they are like suicidal, but maybe they've had a lot of death in their life recently, something to pull out, you know, and it can be very telling. So I never saw anything like this, but one of my undergrad professors told us there's I don't actually know if it's a photo or just a very photoreal painting in the set that's just like a bench looking over a lake. And my grad school professor told us that they had a client once who said, well, you know, someone's going to come sit on that lake because he's watching the people that he just drowned. Right? Very different than like, oh, what a serene place to sit and watch squirrels. Right? So that can be very telling. Sentence completion, I think, is the one that's most often given if you want to include a projective for a couple reasons. One is that it's short. It's self-administered, so you just hand it to the client. And so there are a series of sentence stems. So things like I wish, or again, because it's Freudian, you got to have one in there that says my mother, right? And you have them just write a sentence starting with that phrase. And so, again, this can go a whole bunch of different directions. I wish, that COVID was over, right? That's where a lot of us are here right now. Or it could be, I wish, that so-and-so would die, or I wish that I wasn't feeling depressed all the time, or I wish that I could eat normally. I wish that I wasn't so worried, and something like my mother can be different of like, my mother's a very caring person versus my mother's the worst person in the world, right? So I've given several sentence completions in my life. And again, you just sort of look for patterns. There does exist one that does have standardized scoring. But typically I've just seen, again, sort of a therapist interpretation of this. So let's stop there today, because the next thing we're going to get into is personality inventories. And that's a pretty lengthy chunk of our lecture. So we will do that when we get to Tuesday. So, alrighty, so I will do my normal hanging around for a couple of minutes in case anyone has questions. If not, I will see you on Tuesday. I know I'll see a couple of you on Monday.
Have a great weekend.
You too.